Welcome to the Turd Nerds. We are the functional gastroenterology podcast discussing all things poop. Before we take the plunge into today's episode, let us tell you a bit about ourselves. I'm Dr. Rebecca Sand, a naturopathic physician and acupuncturist, and I specialize in all things gastroenterology, hormones, and fertility.
I'm Dr. Ami Kapadia, and I'm a medical doctor trained in family medicine and functional medicine with a special interest in gastrointestinal health, food and environmental allergies, and autoimmune disease.
And I'm Dr. Ilana Gurevich, a naturopathic physician and acupuncturist who is board certified in naturopathic gastroenterology. I specialize in inflammatory bowel disease, IBS, and other functional digestive disorders. Let's jump into today's episode.
The following discussion is for educational purposes only and not intended to diagnose or treat any diseases or conditions. Please consult your doctor before incorporating any of this information into your care. The information presented on this podcast is not medical advice.
Hi, Turds. Welcome back. We are going to be talking about ozone today, but not the kind in the sky, the kind specifically of the rectal variety.
Medical.
And medical. So lots of uses for this one. And we're going to kind of do a deep dive into why we use this, what we see, how it works, all of that kind of stuff. Would you like to kick us off?
Rectal ozone happens to be one of my favorite tools for inflammatory bowel disease. And I stumbled upon it many, many years ago. And I probably do more rectal ozone for inflammatory bowel disease patients maybe than anybody else in the world.
Is it ozone, medical ozone, the one you said most of the research is from Russia? No, I don't remember what you said.
There is some data on rectal ozone that comes out of the Middle East.
Okay.
There is some data that comes out of Asia. There is not a ton of rectal ozone data.
Okay.
And I did try to publish some of my rectal ozone clinical case series.
But ozone in general, medical ozone in other countries has been studied a lot more, right?
Yes.
Than the US.
Yeah. More intravenous.
Yes. Okay.
I tried to publish my data. The problem is I'm a clinician, and to publish case studies, you need to maintain just one series of treatments to show efficacy. And I never do that. So I had a researcher come in and do a retrospective look at my case studies, but there was only one intervention. So I couldn't publish myself.
Yeah.
Okay.
Too many variables
because we practice individualized medicine. Like that's what naturopathic medicine is. Rectal ozone was first patented by Tesla in the 1930s. 1910.
Tesla?
The first ozone generator was patented by Tesla.
In the 1930s?
1913.
13?
Yeah, I didn't know that either.
Yeah.
You can continue.
Yeah. So Tesla was the first person Tesla was the first person who ever patented an ozone generator. Nikolai Tesla.
Rebecca's thinking about the car company and she was confused.
It's like Elon wasn't even alive.
Nikolai Tesla, the first ever ozone generator. So let's just start with what is ozone, right? Okay. So this is the analogy that I always give patients. We take oxygen, which is a very stable molecule.
Yeah, O2.
A husband and a wife, very stable molecule. And then what we do is we electrocute it, right? And when you electrocute it, 30% of that gas will reform in very, very unstable O3. A husband, a wife, and a girlfriend, right? Or a husband, a wife, and a boyfriend, or whatever. Right. It's not going to...
This is your best analogy?
It is, actually. It's very, very unstable, and it's not going to last. Because that third electron is looking to become a pair, right? It's not comfortable in the form of O3, which means that 30 minutes after electrocuting that oxygen, 100% of it will be oxygen again. So for 30 minutes, you have this active property of ozone. It's very, very unstable.
Yeah,
but if it's sealed in a ozonated water, etc., doesn't it last longer?
Oils and waters will keep it in that ozone form for longer.
Yeah.
Absolutely. But the question is how long?
Yeah.
We think that if you're ozonating an oil, especially a polyunsaturated oil or a monounsaturated oil, you can actually keep it in consistency, ... But if you're in gas, it's 30 minutes. If you're in water, you probably have a longer half-life on it.
Does it still smell like ozone in the oil?
Yeah. Oh my God. It smells so bad. Just as an aside, right now, my son has he's starting to form some dental caries between his teeth, and our biologic dentist has him using ozone oil on his floss.
Awesome.
And that can reverse it, but it tastes so bad. He hates it.
Oh, really?
Yeah.
That's so smart, though.
Yeah, it's so smart. And then it can prevent drilling and all that.
Totally.
You just scoop some out and put it on the floss?
That's exactly what you do in the new floss.
He's actually doing it?
I mean, we've learned our
What
lesson.
does it taste like?
Oh my God, so bad.
I mean, ozone smells bad in
I know.
general, right?
It
So
smells
probably
weird.
it's a combination of olive oil plus ozone.
So everybody who lives in a state that has thunder and lightning storms has smelled ozone.
Yeah.
Ozone is the byproduct of when electricity, lightning breaks through oxygen.
Yeah.
Right? And so naturally ozone occurs in our atmosphere during lightning storms. We also have the atmosphere ozone, what was that called? It was a big thing in the 90s.
Yeah, it's like the hole in the sky.
Yeah, the ozone layer or something.
Yeah.
That was a big thing in the 90s where we were worried that our ozone layer was going to disappear and that was going to affect the the environment. So ozone occurs naturally in the environment.
Yep.
We are just speeding up that process using an ozone generator.
Yep.
There's also ozone generators that are medical grade or just air ozone generators. Right now, ozone is used a lot in the restaurant industry.
For odors.
In the
Water.
hotel industry.
Don't we use it to purify water?
Water purification. It's in treatment facilities, in water treatment facilities. We also use it in actually to manufacture denim. Ozone is a gas that they use to make denim change colors. So instead of indigo dyes it, but like changes the consistency of the denim. Yeah. So we use it in industry. And we use it medically. It's very important to know that the ozone that we're discussing here is a medical grade ozone, which means we take medical oxygen that is exclusively O2. We run it through the ozone generator and out comes a gas which is the medical ozone gas. I also own actually Dr. Kapadia's old ozone generator because
for the environment. Yeah.
I would never tell a patient to just buy an ozone generator that you do not hook up to an oxygen tank and use that rectally because that is not pure O2.
Yeah, you need the canisters.
You need to control it.
Yeah.
I do use the medical ozone generator if there is an odor. Yeah. It's very effective for that.
Yep.
You just can't breathe it in. So
thank you.
Yeah.
Let's talk about ozone. Yes. So ozone is safe everywhere in the body except for the lungs. It is dangerous for the lungs because you have a bunch of very fine micro villi or alveolar sacs in the lungs, and ozone just like burns holes through them. So ozone is safe if you put it in the IV mixed with blood. Yeah. I don't think it's safe just direct IV.
Yeah.
But ozone is safe if you mix it with blood. And a lot of the data we have on ozone is that using blood ozone. Ozone is safe if you put it rectally. Ozone is safe if you apply it to the skin in a contained surface. But if you start breathing it in, you will cough. And if you are decompensated respiratory, it's not a great treatment for you because it'll make your lungs
like
even more.
COPD, emphysema,
and
asthma.
People use it at injections too, right? Joint injections.
Oh my God, joint injections. It's so effective for joint injections. Thank you. I forgot that. Yeah. Yes. Very, very effective for pain.
Yeah.
But we're a turd nerd podcast.
Right.
That's right.
So we're talking about ozone rectally. So why don't I give you guys a history of how it works and what it does?
Yep.
And then we'll do some clinical case.
Sure.
Okay.
Sounds great.
The reason why we're doing this episode is because I got a text from Dr. Sand last week that was like, oh my God, ozone's amazing. It got 2 of my patients who were totally flared out of a flare.
Yeah, and saved them from surgery. They were both scheduled for surgery and their gastro said, let's put this off, which is amazing.
That's ozone.
Yeah, I mean, it is. It's super cool. And it's, I feel like the hard sell on it is putting something up your bum. But honestly, people with IBD, you put stuff up your bum.
Yeah.
Like you're kind of used to it. We do worse to people than the ozone. So,
and it makes them feel better.
It makes them feel better.
Yeah.
And that's worth a lot. So
okay, so let's talk about what it's doing. So really the function of ozone, it's that third electron, right? That very, very unstable third electron. And it is doing 3 things at exactly the same time. 1, it is coming in, you're putting it rectally, and it is coming in and it is basically finding tissue in the GI tract that is inflamed.
Are we going to I was going to say we could guess the 3 functions.
Oh, let's do that.
Well, isn't it a pro-oxidant?
Yes.
Okay. And isn't it creates inflammation?
Yes.
It binds radical oxygen species.
As an anti-inflammatory. So it's both pro-oxidative and anything.
And it triggers inflammation, but then you get healing from that, right? And then I don't know the third one.
Antimicrobial.
Oh, right. Of course, because we do that.
I just want to say, as someone who supervised Dr. Sand a lifetime ago, I am very, very proud.
I wonder if that's why it works for joints sometimes, because there's the old research on microbes and osteoarthritis and rheumatoid arthritis.
Okay, so let me talk.
Anyway,
cool.
I made thought of that.
Let me tell you what it does, and then why I think it's doing that plus other things. So the first thing is it goes in and it's pro-oxidative, it's pro-inflammatory. It upregulates the natural inflammatory response because it will go in there and it will find any of the cells that are inflamed, damaged, and angry that the body has not extruded or kicked off. And it will start the process of inflaming it so much more that the body now says, oh, there's no healing this cell. Let's just get rid of it.
So it's kind of like it brings a magnifying glass to the areas of inflammation that maybe the immune system hasn't given enough attention to, and like points those out.
And those tissues become so damaged, the body can no longer try to save them.
Yep.
So that's the first thing it does.
Yep.
It causes inflammation locally where you're already inflamed.
Yep.
However, if you have a healthy cell that is not inflamed, there is no place for that electron to get in. So no damage happens to healthy cells. Only unhealthy cells get in. So that's the first thing it does. The second thing it does is 6 hours, and we do have animal data showing that 6 hours later, that third electron goes directly to the mitochondria and like hyperdrives an increase of reproducing the cells that just got damaged. So for the first 6 hours, it's inflammatory. And then for the next 72 hours, it's anti-inflammatory, and it reheals and it re-replaces those cells that just got kicked off.
So it kicks up regenerating tissue to help heal the damaged tissue that it kind of moved out of the way.
And the entire electron transport chain runs on these electrons, single electrons, which is what this O3 molecule provides as a single electron. So it like hyperdrives mitochondria.
Yeah.
The third thing that it does is what Dr. Kapadia was just saying. It is super antimicrobial. And it's especially antimicrobial for anaerobes, right? Like we are basically hyperoxygenating a very anaerobic area. And so it preferentially downregulates anaerobes and basically gets rid of pathogenic bacteria, not protozoa, not parasites, not worms that I know of, but definitely anaerobic bacteria.
Which are creating problems in there.
But they're not always creating problems.
No.
Is it selective?
It seems to be selective, yes. And so it's very, very effective to not only change the mucous membrane and heal up those ulcers, but also to change the microbiome.
So for those of our listeners who don't know how we get it up the rectum, the way this works is you go into a clinic, like your clinic, and fill a bag. It looks almost like an IV bag full of ozone, air, and it looks like just an IV bag full of air. And then we put a little catheter on the end that has holes in it, and you put it just a bit into the rectum. You want to get past the sphincters.
You want to get past where the holes are on the catheter. So like 1.5 inches.
Get that in. And then, just sort of at your speed, you just decrease or squeeze the gas in. Obviously, gas in the rectum comes out. So, patients will pass gas, sometimes urgent bowel movements along with it, maybe some cramping, things like that. But we are putting gas up, like literally just squeezing gas up into the rectum. That's how we get it there.
Yeah. So I've done this on myself. Have you ever done it?
No.
And you've never
told me too many times.
I know. I usually have tried everything.
She's tried everything.
Do you tell them to wait till after they have a bowel movement?
So let me just give you my experience. So I love rectal ozone. I actually lecture about it quite a bit.
Yeah.
My experience with rectal ozone is, I insert the catheter. The catheter is like smaller than a pencil.
Yeah,
it's a very small catheter, but we provide lubricant if that makes you more comfortable. And I had a 750 cc bag, so that's a lot of gas. And I inserted it into my rectum. And the problem with a large intestine is its job is to squeeze and push down.
So it has that sort of reflex that if it distends with gas or fecal matter, it gets it out. Like we are built to do that.
And so it's, you feel bloated and crampy. I felt it was very uncomfortable for me when I did it. And I've done it multiple times.
Was it worse the first time?
Yes.
Because that's what patients say.
I also feel like I think I'm always in a hurry.
Yeah. Really?
Shocking.
And so I think that I squeezed the bag. I inserted too much too quickly. Right?
Yeah.
So I had crampy. And what it did is because I'm putting gas in there, the large intestine is like, I'm too full. So it squeezes and dumps.
Yeah.
So it will actually induce a bowel movement.
Oh, okay.
And then you stop, have the bowel movement, take a little break, and restart again.
Wouldn't
And
it work?
I would say if you're like about to have a bowel movement, like get that out first.
Well,
before
wouldn't it
shoving
work
gas
better
in
to
there.
get to where you want it to go if your colon wasn't full of stool? And
Absolutely, but I personally cannot poop on demand.
sure. But if people have a
That would
regular
be
routine,
amazing.
they take the bag home, right?
So
or you can't, it doesn't last that long, right?
That's the problem. You
Okay,
have
so
30 minutes
right,
on
right.
that bag
Okay.
before that bag is
So you
oxygen.
can't really coordinate it like that.
So most people will just come to my clinic and
Yeah.
administer in my bathroom. They do that all day long.
And they do it by themselves.
It's
easy peasy.
Very private. We have more than one bathroom in the clinic. We take care of it. It's not a problem. If they live within 5 minutes of the clinic,
yeah,
go home.
then they could go. Yeah,
But you got to go home and do it right away.
right.
But generally, because it has such a short half-life,
Yeah.
And any risk of like causing any side effects, like from inserting that amount of gas, all of it all at once.
yeah, you are really damn bloated.
But that's it. It's not any. There's never been any like serious potential.
It's gas.
yeah.
You know what I mean?
So
Like
it can't
it's
cause
not-
any kind of perforation. Or
It's not going
anything.
to cause any
Yeah.
perforation. It is a gas. Worst case scenario, you don't get all of it in.
Right.
And I do not always use 750 cc's. For ulcerative colitis patient, I'll use 250 to 300 cc's.
Mhm.
And then for a Crohn's patient, I'll use 750 cc's.
Because you're assuming it needs to go farther up the bowels.
Here's what happened. So I was trained by Dr. Schallenberger, who runs the American Academy of Ozone. He does phenomenal trainings. And I've actually spoken at the American Academy of Ozone about ulcerative colitis treatments with ozone. And I had a patient he lived and worked 35 minutes from my office. So having him come to my office to administer rectal ozone was like prohibitive for him.
Yeah.
And there's a really, really solid ozone doc right by where he worked, right? And so I called the clinic and I said, are you okay if he just goes and fills his bags there and administers there? And they don't do a lot of rectal ozone. So at that point, I was having most patients fill half a bag, right?
Mm-hmm.
So 300 cc's ish. They didn't know what they were doing, and they filled the 750 cc bag and he administered it. And then he comes in and he reports and he was like, I was burping ozone. Like it was so gross. I was burping ozone. And I was like,
Portal
I can do
situation.
it through the small
Yeah.
intestine. I can use it in the entire small intestine now.
Just get more
This
gas
works for
up there.
Crohn's. And so Crohn's patients who have most of their disease in the terminal ileum get much larger administrations.
Yeah.
They get 750 cc's. They will be burping ozone. They will be gassy and bloated and crampy. It is not a comfortable experience. You see patients get less. Proctitis patients where their disease is like, 2 inches up
Yeah.
will get 60 cc's.
Yeah.
Have you seen it heal proctitis?
Yes.
Seems like a good. Yeah.
You know what it also is effectively
The
really
fissures?
good at? Microscopic colitis. But it's very effective
What
for
dose are you giving for that one?
UC dosing,
Yeah.
250 to 300
Yeah.
cc's. And, I am administering usually right around 40 micrograms per milliliter.
Yeah.
We used to call that 40 gamma, but now we call it 40 micrograms per milliliter. That's about the dose that I'm using.
You start people on a smaller dose.
Usually I'll start lower quantity, lower strength,
Yeah.
and then I'll move up.
Yeah.
And if they're actively bleeding, then I'll go even higher in my microgram per milliliter dose, like usually 60-ish.
Yeah.
And sometimes you have them get a machine, right?
I also, so
Sometimes-
one of the things that it was really prohibitive to come to my office.
Yeah.
So we actually do now loan machines out weekly for
Yeah.
patients if they want to administer at home,
And we should say that typically people are doing this a couple times a week.
if not every day.
Yeah. And
If they're acute, they're doing it every day.
right. Yeah. And it's often weeks on end
Yeah.
that people are doing
Yeah.
this. So having to drive into a clinic, like when.
But you're
during
open on.
COVID for, like,
Oh well, but
hours.
that's only one day if they come Saturdays. So you have
Yeah.
to come 2 other days.
Right.
Yeah.
Yeah.
And so the resident machine has actually been really effective. And the other thing that happens is if they have a very good response to ozone, we actually just have them buy their own machine.
Yeah.
Yeah.
Like if it's something that you're going to use a lot,
Mhm.
and some of my patients have amazing benefit from it, they just buy their own machine.
Yeah.
The other thing with using ozone is I will, with my IBD people, I will get some kind of baseline marker. For UC, it's a calprotectin. For Crohn's, it might be a calprotectin, or it might be a blood test, like a CRP. And then I have them do the intervention for about 3 weeks,
Yep.
and then take a week off. Because I have learned the hard way that ozone is pro-inflammatory before it's
And that
anti-inflammatory.
might show up on your marker.
I have seen it show up on the markers. I have seen a baseline calprotectin in the 300 or 400s,
Mhm.
and then where they're doing ozone, they rerun the calprotectin, it's 1200, but they're feeling so much better.
Right.
And I'm like, this doesn't make sense. Let's take a week off. And then the calprotectin drops to 60.
How are you using that baseline to determine what kind of treatment you're going to give them?
The higher the calprotectin for UC, the more aggressive the treatment. And, with ozone, it's pro-inflammatory before it's anti-inflammatory. So you do want to give the body a chance to heal.
Yeah.
So if they're bleeding, I'll usually do every day administration. If they're just flared, I'll do every 2. Yeah. And then I don't often use it for remission patients. Like it's
for flares.
It's for flares.
Yeah.
It's kind of my equivalent to a steroid. Does it work for everybody? No, I wish it did. It doesn't. Does it work for a lot of people? Yeah.
So in terms of what people can expect, like symptom-wise, what I have seen with folks is the first one's usually the worst. People usually get the worst cramping from that first dose, which I think is why we're giving like a lower gamma dose and a smaller sac of air to put up there initially. It tends to get better, but usually by like the third one, people are feeling like, you get your rhythm down, you know what to expect. It's not, I think people also tense up their first time because they're nervous, like perfectly reasonable. That makes sense. Doesn't help the rectum really, but it's just sort of like you pop in, you do it. It's not a big deal after that. Yeah. Maybe some diarrhea, but like these folks have diarrhea.
Yeah.
So, and
I would agree.
Beyond that, I've had 1 or 2 people that were dizzy, but who knows, what that was attributed to. Were they so worked up because it was a new thing? I don't really see anything else from it.
So give us give the cases that you texted me about.
Yeah. So I had one that was stricturing.
Strictures.
Yeah. And I would love to pick your brain on that one as well, because this patient wasn't responding to anything. Like none of the drugs, nothing. And, they plopped in my office.
This is ulcerative colitis or
no
Crohn's?
It was a Crohn's.
Okay.
And I'm trying to remember where the stricturing was, because I was doing abdominal therapy on him and it was like left-sided, but I don't remember what the report said on it. But we did, a lot of the herbal things that we'll do along with it and the ozone. This guy had no symptoms. He never had any symptoms. But the stricturing was so bad, they were going to be removing, a piece of the colon because it was dangerous, obviously, for
This is from colonoscopy. Okay.
Or imaging. I don't know. I don't think they could get the scope up
wherever
there.
it was. Okay.
Yeah, like an MRE or something.
Yeah. So we did ozone and all the other natural stuff to see, what we could throw at it, because he hadn't responded to a thing. And I was rubbing his belly and doing the abdominal therapy and just getting good circulation. And he was scheduled for a resection. And then they went and did imaging again, and they said, let's push it out. Things aren't moving. In fact, there might be improved. It's hard to tell, but there wasn't like active warning signs of needing that. And they were able to push it.
I wonder why they redid the imaging if they were planning surgery.
I think they wanted for it. I think he was due for I think they were basing it off something else, like some other marker. And they were just proposing it when they got him in. It was too late. They wanted to re-image, I think is what happened. But yeah. I mean, amazing.
Yeah.
He had no symptoms. And he was like, why? Like, I don't feel anything.
Yeah.
What's going on? And he was totally willing to do this stuff. And, who knows what it was, but it was very actively inflamed.
Yeah.
Despite no symptoms.
Was it an incidental finding that he was diagnosed with Crohn's?
Found? That's a really good question.
Okay.
I think maybe it was like a screening colonoscopy.
This is going to give a plug for the book that I was recently reading.
Yeah.
Overdiagnosed.
Totally.
Yeah, give it
and he may have had a blockage or something that would have wiped him out if they wouldn't have found it. Let me think about how they did find it.
And I will say strictures are hard to treat and manage, both conventionally and alternatively. I have personally had a patient in my office be totally good, asymptomatic, and 3 days later acutely in the hospital with
it's so variable
obstruction.
Yeah, they moved the surgery out because the stricturing was stable, but the inflammation had gone significantly down when nothing else had touched it. That's what happened. So I think they were imaging to see if they could perform surgery based on the inflammation.
Yeah, sometimes they redo the imaging for surgical preparation.
Yeah, so. I think that was what was happening. So, and they were like, obviously we're going to continue to follow up, but they took it off the books of like, we need to get this thing out kind of thing. So,
and so you were talking about the book that you're reading.
Overdiagnosed. I finished it, but it's kind of depressing.
Because it talks about how we do so much screening.
Yeah, and then you get an incidental finding, and then you chase that down, and then you chase the next one down, and it leads to all these unnecessary procedures. But you have to be okay with like some minimal risk of missing things if you're going to try to be more logical about guiding people in treatment.
I've had a lot of patients, younger patients now, who want like the full body scan thing. That's
a horrible idea.
Yeah, and we were talking about this earlier, but like bodies grow stuff.
Yeah.
Bodies grow stuff, and bodies also get rid of stuff. Like we are built to do that. And the more we take photos, the more we find stuff in the photos. And then if a doctor finds a stuff or a thing in a photo, you got to biopsy it.
Right. Yeah. And they were talking about like thyroid cancer and how there's so much more thyroid cancer now, but the mortality hasn't changed. So that tells you that we're over-diagnosing it. I mean, he says it much more with statistics and such.
And like doctors don't want that liability of like if it is the person that died. So of course people push intervention.
In America especially.
But to what end?
I think places with national healthcare systems are running aggregate data differently. And so prioritizing differently. That's honestly one of my hacks for my patients that I always tell them is
look up what they do in other countries.
Whenever I make a recommendation, I look at what the NHS does in the UK and what the Australian National Healthcare System does, mainly because they're national healthcare systems and they speak English. And I used to look at Canada too, but Canada is very influenced by what America does because they're our neighbors.
Yeah.
So my recommendations, and I educate my patients, don't trust me. You can look at what I can. Go look at what the UK is saying. Look at what Australia and New Zealand are saying. Are they in alignment? How does that compare to what the US is saying?
Also, like there are such big capitalistic ties to our healthcare system. Like the system profits the more we order imaging studies.
I know. And he talked about, this was really concerning. You know, like the Costco, like how they have their rotisserie chicken to get you in the door.
Yeah.
So hospital systems can have some free cardiac calcium score screening or not to say that you shouldn't get it, but to get you in the door because they've run the numbers on how much more procedures they can then do.
But testing isn't without its risks.
Testing, and any testing, honestly, even with dyes, we now know there's a lot of risk with the dyes that they use. Is there a time and a place for testing? Yes.
Yeah, thank goodness we have it.
Yes.
Just like use your brain.
But is there a time and a place for testing your whole body in your 30s for no reason? No.
Yeah.
Or just to even just before you're getting any imaging test, do you really need it? But that's the problem because we don't want to miss anything.
Yeah. And people
are wanting the test.
Afraid. I feel like people are more afraid, at least in the States, more afraid now of medicine than they were in the past.
I mean, I'm afraid. Yeah. I don't want anything. It's hard to argue with the doctor, even if you're a doctor.
Exactly. And a lot of people don't get heard. So they're kind of like venturing out on their own path to find their own stuff.
And the doctor, I think, is not there to do harm. But
they have guidelines.
They have to carry their own liability and their risk. Yeah.
And we are such a litigious country.
But that being said, sometimes you find a stricture.
Yep.
Right.
Okay. So that was
I gotta remember. Yeah, that one. And then I've got another case where it's a patient who had a fistula that we'll go over when we get to our fistula. It wasn't the bulk of this person's problem, but there was just super inflamed descending colon on and off. Like you could feel it. And she's been doing the perineural injection therapy that I also think has been helping. Yes. And the abdominal therapy like every other week, just getting circulation in. And that was keeping things at bay for like probably a year, I would say. Calprotectin stable, everything stable. But because of the fistula, she keeps getting urinary tract infections.
That's why for that kind of patient, that'd be amazing if you can heal the fistula.
For sure. And she had a ceton, didn't hold due to a large bowel movement. Big bummer right after the fact. Huge bummer. Yeah. But the only thing, like we know so much for UTIs. Nothing worked.
Nope.
So this person needed antibiotics and repeated antibiotics, flares, So ozone is sort of what's helping to keep everything at bay, both like in the local area, but also rectally. Yeah. And then now we're trying like ozone suppositories.
Yeah. Rectally or vaginally?
You could do both, I guess.
Yeah, I want to say they're doing vaginal.
Does it work as well in a suppository?
So
I think vaginal.
It really comes down, the thing about a suppository, any suppository, is the suppository is going to cover the tissue that the suppository covers. It's not going to spread anywhere. It's not.
But the ozone is still active in there?
Oh, yeah.
With the time?
It's in an olive oil.
So that like holds it for much longer.
Yeah.
Yes. Okay. So the thing about the oil is those electrons are just getting lodged on those poly or monounsaturated fatty tails. You guys remember the tails? Yeah. So the fat is almost like freezing. Ozone oil will maintain the ozone strength forever.
Okay.
Because the fat, until it turns to liquid.
Yeah. Or it becomes, until it degrades.
Right, because the fat holds. So you don't need to refrigerate ozone oil.
Yeah, they just ship it. It's wild.
Yeah, and it's very effective. It smells so damn bad. It really smells bad.
Yeah, this person I'm also doing like vaginal probiotics, herbal suppositories. I mean, I need this antibiotic to stop because it's just these flares and I can feel it with my hands. Like the swelling and like angry colon is quite palpable. The injections have really helped with that, but I mean, I mean, not that that's a biomarker
Yeah.
of like what my hands are
Yeah.
feeling, but
But it is an important.
it's a thing. Yeah. And just like everything we can throw at it.
I wonder
is
what
magic.
is the incidence of rectovaginal fistula in inflammatory bowel disease patients?
It's not as uncommon as you think. I don't have that stat, but I really should. It's a shame that I don't.
You know, another case back 100 years ago when I was your resident, there was a young patient who had a fistula and was on metronidazole for 2 years. Ridiculous. Like quality of life was nothing. And this poor kid, and we did rectal ozone applied topically, or it wasn't rectal. It was like a topical.
It was a fistula. It was a rectal anal fistula.
This poor sweetheart. Yeah. But I was holding the ozone with the machine. Yeah. The little like cone over, and we got him off the metronidazole. Amazing. Because it was oozing. I mean, even with the metronidazole, it was like oozing, seeping.
What kind of fistula was it?
It was like a rectal enteric fistula. So it was a fistula that went from the large bowel to like the polynodal tract.
Yeah.
Which
and that's
angry. That's also that's one of my treatments that I do for fistulas. Is I do put ozone on there. It's a harder treatment to do, especially on the cleft, because you're never going to get a full suction.
Yeah.
So like I had Dr. Sand in there holding the cup with towels, applying pressure for 15 minutes, trying to catch the
repeatedly
ozone.
over and over. But I don't know what the follow up on that was, but
he never visualized again.
Amazing.
Yeah, he's actually pretty stable. He was a very complicated patient.
Yeah.
Yeah. So it is this. It's like it's cheap. You know what I mean? Like, honestly, it's cheap. It's very, very effective for some people. And it's nice to have that tool be a tool that we have in our tool belt.
Yeah.
Can we always guarantee it? No, it's still medicine. Yeah. But is it if you're not opposed to sticking something up your butt, and just spoiler alert, I also have multiple patients who were bound to get amputated because they had gangrenous lesions on their limbs, terrible uncontrolled diabetes. I had 2 patients with Wagner's, which is a disease where the capillaries just die and they get gangrenous necrosis on their limbs like that. A patient went from healthy limbs to gangrene in 3 days with an acute autoimmune reaction to the vasculature. I have saved limbs using limb bagging ozone. So you put the limb in a bag with ozone gas running through it.
You like tape it up.
2 patients with Wagner's, 1 patient that had necrosis second to a failed surgery when they put screws in their legs, a healthy patient, and the body was rejecting the screws and they got gangrene. And a healthy adult, I had their limb bag completely resolve the lesion in like 2.5 weeks. Now, if you tell me that you're having a reaction to metal in your body, I almost feel bad for you because I'm going to be so aggressive with my demands that you rent my ozone machine.
But then what do? You try to get the screws out?
I get the first thing first.
Right, but after it heals.
And then they usually have to get the screws removed.
Where I really think about the limb bagging is for IBD patients that we're trying to keep off antibiotics. So if they do get some kind of skin issue that we would consider antibiotics for, like we do need that. Can we buy a bit of time? Can you come in, a couple times or just do it yourself and see if we can use ozone to get that infection under control and get the antibiotics out of your gut?
Can you use the topical for that too?
So my answer is I don't know.
Yeah.
Because I have
maybe not as aggressive
good success with the limb bagging.
Yeah.
That it's like so serious that I have trouble.
Yeah, you don't want to change.
Telling you to,
So for ulcers, they do use hyperbaric oxygen, but they don't use ozone traditionally still?
No, but there's also great data on fistulas with hyperbaric oxygen. If we're honest, more data on hyperbaric oxygen with fistulas than ozone.
Yeah.
Because ozone is so cheap, nobody's incentivized to study it.
Yeah.
But so there's that.
Do they use hyperbarics for fistulas? You do you lay in it like the normal way?
Yeah.
Interesting.
And they use,
like GI doctors would refer someone?
I have no idea. But I've seen the studies on it.
Huh.
I've read the studies on it.
Okay.
And what made me read the studies on it is an IBD patient with fistulas who was also a nurse. She told me she found the studies and then I did the lit search and died.
You probably have to still send them to a private.
Hyperbaric is so expensive.
So someone who has a unit, because they're only going to use it in a regular clinic for ulcers, right? At this point, diabetic.
All of the data on hyperbaric is using a hard chamber. And what most people have is a soft chamber.
Totally.
The soft chamber probably has the same efficacy, but it doesn't have the same data. And, soft chambers are 25 to 30,000. Hard chambers are 100 to 150,000.
Yeah.
So, a clinician's only going to have access to soft chambers, but we do anecdotally see the same response.
Yeah. Cool.
But that's a totally, it is. These turd nerds, thank you for tuning in. By the way, I just want to say, at this point, we have over 57,000 downloads. Like, people are tuning in and listening.
People
Thank
got
you.
Problems.
We have not even scratched the surface of what naturopathic treatments and functional medicine treatments can do.
Yep.
There's so many avenues. It's amazing. We live in a world.
I feel like every time we're kind of like, oh, what are we going to talk about today? It's just like, oh, this, like, oh, this person I saw this week. You know, it's what we get to do is so fun.
So fun. It's like the best job in the world.
It's really cool.
Okay, recap. Sorry, little plug for naturopathic medicine. Recap.
So ozone is antimicrobial, antioxidant, inflammatory,
antimicrobial.
Yep. And we use it rectally for inflammation, to get the inflammation
acute flares
sloughed off.
Inflammatory bowel disease, all three, microscopic colitis, ulcerative colitis, Crohn's, any three of those, we can use it for acute flares, usually 3 times a week to daily. You go to the clinic and do it, so you have to kind of work it in or eventually get your own machine if you need it for flares.
Safety profile is pretty
no
excellent.
Side effects except
breathe it in.
Uncomfortable.
Yep.
Don't breathe it in.
Yep. And then you can also use it topically.
And I will say microscopic colitis is not an IBD.
It's sorry.
Somewhere between IBS and IBD in its own little weird category.
Okay.
But still effective and kind of a response to the same treatments that IBD.
Because otherwise the treatment is budesonide, is steroids, right?
Steroids, budesonide.
Yeah. Cool.
All right. Thanks for tuning in.
Thanks for joining us today. Stay tuned. We release episodes every 2 weeks.
If you like this episode, please subscribe and don't forget to rate and review us to help spread the turd nerd word.